Welcome, focused learners, to this explainer. Okay, let's just dive right into it. Today we're unpacking the really fascinating, incredibly high-stakes world of medical billing and coding. And listen, if you think this is just, simple data entry, think again. Medical coding is a rigorous, highly logical system, and it is governed by some incredibly strict rules. So today, we're going to master the rules of the game. We'll be breaking down exactly how bundling, modifiers, and reimbursement mechanisms actually work behind the scenes to keep the entire healthcare revenue cycle moving.
So here's our roadmap for the explainer. We're covering 1. The core of medical coding, 2. Bundling basics and pitfalls, 3. Radiology and split billing, 4. The magic of modifiers, 5. Relative value units, and finally 6. The claims matching process.
All right, let's jump straight into Section 1, the core of medical coding. I really want you to think about the sheer responsibility placed on the coder here. Every single piece of information from a doctor's report, every symptom, every diagnostic test, every treatment, it all has a unique code. The coder's job is to accurately extract that entire narrative from the clinical documentation and translate it into CPT and ICD-10 codes. Because honestly, without this precise alphanumeric translation, computer systems simply cannot comprehend the care that was given, and the entire billing process just stalls out completely.
Professionals in this field often joke about coding drama. For a very good reason. There is a staggering number of distinct codes and procedures out there. And because every single code set comes with its own unique, rigid set of regulations, a claim's status relies entirely on following those exact specific rules. Literally one misaligned sequence and boom, the whole claim gets rejected. It's basically a high-stakes puzzle.
Moving on to Section 2, bundling basics and pitfalls.
Okay, so an absolutely crucial point here is understanding what bundling actually means in practice. Bundling refers to steps that are entirely necessary for a primary procedure to be successful. Think of it like this. If a surgeon performs an operation, they have to make an incision, right? And when they're done, they have to close that wound. You cannot bill separately for closing the surgical opening, because closing up is just an integral, necessary element of the main surgical process itself. It's bundled into the primary code.
But what happens when a doctor does extra work? Well, this is where we contrast incidental procedures with separately reportable ones. Say a surgeon is already inside a patient for abdominal surgery and decides, hey, let's remove the appendix as well. That is an incidental procedure. You are already in there, so it's not billed separately. However, if a surgeon operates on two completely distinct body parts, like say removing the meniscus on the left knee and then shaving cartilage on the right knee, that is separately reportable. Those are distinct procedures that absolutely justify unbundled codes.
I really want to pause here for a second because this is a massive compliance issue. Unbundling codes strictly to extract a larger sum of money from a payer is never, ever acceptable. Take pathology and clinical laboratory services, for example. If you bill for several individual lab tests, when a single basic metabolic panel code covers all of those exact components, you are improperly unbundling, period. And the same strictness applies to drug testing. You cannot just swap out a simple qualitative screening, which just checks if a drug class is present, for a quantitative test that measures exact concentrations just to get paid more. You have to have clinical documentation justifying the medical necessity. Doing this intentionally triggers audits, payers will demand repayment with interest, and it can even result in the provider's contract being immediately terminated.
Let's move to Section 3, radiology and split billing.
So imagine a standard X-ray done at an independent facility. Split billing actually divides this service into two distinct parts. The facility that physically owns the X-ray machine, pays for its maintenance, and covers the technologist's overhead, they bill the technical component using the TC modifier. But the physician, the one who sits down, reads the film, interprets the results, and writes up the report, they bill for their expertise using the professional component, or modifier 26. This basically tells the payer, hey, I did the medical interpretation, but I don't actually own the equipment.
This whole scenario brilliantly illustrates why documentation integrity is just everything. Both components have to be distinctly coded to avoid double billing. Think about it. If a physician forgets to use modifier 26, they are essentially claiming they own the multi-million-dollar imaging machine. And when the independent facility also bills for that same equipment, the payer is going to instantly reject both claims. Clean claims totally rely on this exact alignment.
All right, Section 4, the magic of modifiers.
So what exactly is a modifier? Simply put, a modifier is a two-character code added right to the end of a CPT code. It allows the coder to change how a service is described to the insurance company without altering the core procedural code itself.
Essentially, modifiers tell a specific story. They signal to the payer that, yes, this procedure happened, but it was altered by unusual circumstances, or it took place in multiple locations, or maybe it required extra time and expertise.
Let's look at some of the heavy hitters. Modifier 50 is used for a bilateral procedure, meaning it was done on both sides of the body. Modifier 22, that's used when a surgery is far more complex than usual, maybe due to heavy scar tissue, and warrants extra pay. But the real star of the show here is Modifier 59, or its specific X modifier counterparts. These are used to indicate that a distinct procedural service was completely independent from other services performed on the same day. This justifies independent payment even if that service is usually bundled.
But remember, you have to know your specific payer rules. While a lot of payers accept Modifier 50 for bilateral procedures, some commercial payers actually require the procedure to be specified twice on a single claim, once using Modifier LT for the left side and a second time using Modifier RT for the right side. It just goes to show that mastering the rules really means knowing the individual quirks of every single payer you deal with.
Section 5. Relative Value Units.
Medicare and a lot of HMOs use a system called the Resource-Based Relative Value Scale, or RBVS for short. Under this system, the Centers for Medicare and Medicaid Services assigns a specific numerical value, an RVU, to every single CPT code. And these values are meticulously reassessed every 5 years. It's not arbitrary at all. It's a highly calculated metric that, when combined with geographic adjustments and conversion factors, dictates exactly how much a medical service is worth in dollars and cents.
An RVU is actually built from 3 distinct parts. First, you've got the time, expertise, and effort required by the physician. Second are the operating costs, so rent, equipment, and staff. And third, malpractice and liability costs. This third piece is super vital because specialties like obstetrics carry much higher malpractice liability risks compared to, say, standard primary care. And that naturally results in a higher overall RVU for their specific codes.
So what happens when a surgeon performs multiple unbundled procedures in a single session? Well, payers apply a multiple procedure discount. The procedures on the claim are prioritized based on their RVUs. The procedure with the highest RVU, meaning the most complex and expensive one, gets paid out at 100% of the allowable rate. The second procedure is then discounted and paid out at 50%. Understanding how this prioritization works is a massive strategy in accurate billing.
And finally, Section 6, the claims matching process.
So the ultimate takeaway here is that healthcare is a team effort, and so is the billing. Take a standard surgery. You'll actually have 3 separate parties filing claims for that exact same patient. You've got the anesthesiologist billing their highly specific base unit values, tracking 15-minute time units, and applying P1 through P6 physical status modifiers. Then you have the facility providing the operating room, and of course, the surgeon who actually performed the operation. The payer collects all 3 of these claims and runs them through a matching algorithm. And even though the specialties differ, the core procedural narrative absolutely must tell the exact same story across all 3 claims.
Because if they don't match, you have a massive problem on your hands. If the hospital bills for a procedure on the right arm, but the anesthesiologist's claim indicates surgery on the left leg, that raises an immediate red flag. The payer system will halt payment, launch an investigation, and demand extensive supporting medical records from all parties to figure out who made the error. Accuracy up front is really the only way to ensure the revenue cycle doesn't just grind to a halt.
And that brings us to the end of our explainer. The complexity of medical coding is definitely daunting, but it is the absolute engine of healthcare. By mastering bundling, modifiers, and RVUs, you become the safeguard of the revenue cycle. So ask yourself, the next time an operative report crosses your desk, will you just be entering data, or will you be strategically defending the value of the care provided? Think about it. Please like, share, and subscribe to Decode Healthcare with Harshal.